Hello and welcome to the first episode of a two-part conversation series looking at the issues facing people who have been newly diagnosed with arthritis. I'm Gráinne O'Leary, Chief Executive of Arthritis Ireland. We understand that being diagnosed with arthritis can be a scary and confusing time, and that you will most likely have many questions about your condition. A recent diagnosis can bring with it fears and concerns about how arthritis will affect you in your day-to-day life, as well as many questions around what can be done and what you can do to help manage your condition. During these conversations, we will speak with medical consultants and specialists, providing answers to some common questions asked by those newly diagnosed with arthritis. I'm delighted today to be joined by Professor Geraldine McCarthy, Consultant Rheumatologist at the Beaumont Hospital in Dublin and Professor of Medicine at University College Dublin. Hi Geraldine, and thank you so much for joining us today.
Thank you so much for the invitation, Gráinne. Delighted to be here.
Hey, so our topic today is being newly diagnosed with arthritis. So I'm going to start with the obvious question. What exactly is arthritis?
Well, arthritis is a term that encompasses many disorders, but in its essence, it is inflammation around a joint. And this could be any joint, and it's typically characterized by pain in the first instance, swelling, tenderness if you squeeze it, pain on using it or pain on motion, and sometimes with passage of time the joint can look deformed. So that is what a person might see if they have arthritis. There are lots of other musculoskeletal conditions that aren't arthritis, of course, but in its essence that's what arthritis is.
Okay, and you mentioned that there's many different types. So can you tell us a little bit about what the most common forms of arthritis are?
So the most common form of arthritis is actually osteoarthritis. This is sometimes considered as sort of a wear and tear phenomenon that happens with age. It does tend to increase with age, but it's far more dynamic than a simple wear and tear phenomenon. And unfortunately, it is the one form of arthritis that we have very few disease-modifying treatments in contrast to some of the other forms of arthritis that we'll discuss. So osteoarthritis can occur in multiple joints, or it might just happen in one joint. For example, if a person had played rugby and had an injury to their knee, that joint will be more susceptible to getting osteoarthritis in the future. And osteoarthritis is characterized by wearing away of the cartilage in the joint, and then the bone underneath the cartilage tends to react and grow to form little protuberances called osteophytes. And then within the joint, the lining can get a bit overgrown, a bit like seaweed, and produce fluid. So many people with osteoarthritis will be familiar with getting water on the joint or fluid on the knee. And so that they'd be typical types of findings in osteoarthritis. Next, we have what we call inflammatory arthritis. And believe it or not, the most common form of inflammatory arthritis, particularly in men, is gout, which we will talk about in more detail during this talk. Rheumatoid arthritis then would be the more well-recognised inflammatory arthritis, which is one that we will need to discuss because it can have quite an impact on people's lives. But it's, I'm glad to say we've lots of good treatments for it now. And then you'll have the type of arthritis associated with psoriasis, and we'll have the seronegative spondyloarthropathies, like ankylosing spondylitis. So they'd be the very common ones, but there are lots of different forms of arthritis.
So yeah, so complex area.
It is very much a complex area.
And if I might ask you, who is involved in the treatment of arthritis?
So there are a multidisciplinary approach, as we call it, is the best one. Most people will present either to a physiotherapist first or their general practitioner. And then in many cases, the physiotherapist can do a whole lot to help. But sometimes the patient will need perhaps prescription for a medication, in which case they'll go to the general practitioner. The general practitioner might request some investigations like an X-ray or blood tests. And if with the passage of time it appears that the form of arthritis is more complex, then they should be referred to a rheumatologist.
Okay. And that would take us nicely to the point of, how a diagnosis is made. So can you tell us how a diagnosis is actually made?
Well, the most important way of diagnosing an arthritis is to talk to the patient. So take a full history of what their symptoms are at the time and whether they had any symptoms like that in the past, and if so, what was done about it. We will ask them about if there's a family history of arthritis, because in part some of these forms of arthritis can have a family history. We'll ask about lifestyle and experiences in their life or occupations that may predispose to the type of arthritis that they have. And then we will do a physical examination, which is a really important part. So usually by the end of that assessment, if you like, we'll have a fair idea where we're going with it. But then we'll do blood tests and or x-rays, plus or minus ultrasounds or MRIs or even bone scans, depending. And with that constellation of assessments, we're usually able to come up with a diagnosis.
Okay. And then, once a person has their diagnosis, moves on to treatment. So how exactly is arthritis treated, and what are the treatment options? And again, I'm conscious that there are a myriad of conditions here, but in broad terms.
So there isn't any one size fits all, obviously. So what is the patient experiencing in the first instance? Usually pain, reduced mobility, often sleep disturbance, difficulty with doing activities at home. So in the forms of arthritis like rheumatoid, for example, you want to give them an initial reduction in pain. So we will typically prescribe medication, and depending on how severe it is, that will depend on what treatments we will offer. So let's take rheumatoid for an example. So usually they'll have already had perhaps an anti-inflammatory through the general practitioner. Many patients will have had a course of steroids by the general practitioner, because usually they're waiting for an appointment, unfortunately, with a rheumatologist. There are a number of what we call disease remitting anti-rheumatic drugs that we will prescribe, of which there are many. And then if that's not enough, then there are a lot of what we call biologic drugs that will need to be prescribed. So patient involvement in their treatment is extremely important. We try to educate the patients to know exactly what they're taking, what the side effects might be that they need to watch out for, what monitoring they need. And I can't stress enough how it's a team effort. So the patient has to work with the consultant, as it usually is, to manage their disease and take partial responsibility. If everybody works together, the outcome will be best. We find our rheumatology nurses extremely important to help us educate the patients about their drugs and about their condition, to help us organise blood tests for monitoring their disease. We will find our physiotherapists extremely important to help patients do an appropriate exercise program, and also occupational therapists will help us help the patient to do activities of daily living at home and manage their life along with. And then, of course, we need to advise patients about lifestyle effects.
And we'll talk a little bit about that later, further on.
Yeah.
Just in terms of the treatments, particularly for inflammatory arthritis, obviously this is an area that has been sort of really transformed in the last sort of 20 years, 25 years.
Yeah.
And I think one of the things we encounter in Arthritis Ireland is when somebody's newly diagnosed, maybe if they've had a family member with rheumatoid in the past, their experience, of that past maybe family member strikes, a chord, huge fear in them, because they feel maybe their path is going to be the same. Can you tell us just a little bit more about that? Because it's such a positive message about how the disease is treated nowadays that I think it's worth mentioning at this juncture.
It has been transformed. Clearly, I've been in this game for quite a while, and so I have been able to see the effects of rheumatoid arthritis in the past when we didn't have the fabulous treatments we have now. So in the past, you would try drug number one and then you'd bring it to the maximum dose, and when it didn't work, you change it to something else. But at the end of the day, patients would be left with joint deformities. The best treatment they could have hoped for is joint replacement. And remembering that rheumatoid arthritis, for example, is a systemic disease. So not only would their joints be bad, but they'd also experience fatigue, anemia, reduced mobility, awful. Now we have fantastic treatments. So when I see somebody who's newly diagnosed with rheumatoid arthritis, I tell them that really my expectation for them is that the only reason they'll know they have the disease in a few months is that they're taking treatment. I would expect that, and this isn't for everybody, but for a substantial proportion of patients, the only reason they'll know they have it is because they're taking treatment. So our treatments are fantastic. There are so many options now, and there are more options coming on site all the time.
And while you mentioned rheumatoid arthritis there, that would follow for other forms of inflammatory arthritis as well in terms of the treatment options. There's quite a...
But it tends to be that with drug development, they always start with rheumatoid, it seems like, and then when they've established that a drug is good for rheumatoid, then they'll do trials in psoriatic or ankylosing spondylitis or whatever. So.
And can you tell us a little bit just about treatment for osteoarthritis? Because obviously we talked about that at the top of the interview, about it being the most common form of arthritis, but it might be just useful for people watching, for you just to tell us a little bit about what the treatment options are for osteo.
Yes, so I wish I could say the same for osteoarthritis as I've just said for inflammatory arthritis, such as rheumatoid arthritis. We don't have the same disease-modifying drugs, and unfortunately osteoarthritis is becoming more common. People are living longer, and a lifestyle of modern living is exacerbating it, so that people are now more sedentary, and there's an epidemic of obesity, and all of that is exacerbating osteoarthritis. But in any case, osteoarthritis can happen as young as 30. There's quite a family history association with it. So what are the treatments? First of all, in the initial phase, we do tend to use anti-inflammatory drugs, but with the passage of time, concerns have arisen with anti-inflammatory drugs, or NSAIDs, about their side effects. So initially it used to be all about peptic ulcer disease, but now we worry about kidney problems, liver problems, and in a few cases, but significantly, they've been associated with cardiovascular outcomes. So people are more careful about using anti-inflammatories. That said, sometimes the benefit is worth the risk. So there are people that take them all the time without any difficulty. But it has to be said that you have to be careful, and people need to have blood tests and assessments done a few times a year by their GP. Physiotherapy is extremely important. I can't stress enough the role of the physiotherapist. They are magical. So my first port of call for somebody with osteoarthritis is to go to a physiotherapist and work with them and establish an exercise program. The physiotherapist can't do it all. The exercises that people do at home are extremely important. There are some assistive devices that can be helpful, like braces or using a cane, but hopefully people won't reach that degree of problems. Steroid injections into joints can be very helpful as well. But weight loss, even a small amount of weight loss, can make a huge difference, even a few kilograms. So the most important disease-modifying approach now is weight loss in those who have a raised BMI.
And when it comes to taking medications, of course, people are often concerned about the side effects. Yeah. So, you know, what side effects might a person experience?
Well, we'll start with the anti-inflammatories, because they're so common. So people might experience just symptoms like heartburn, diarrhea. Some people get kind of dizzy from them. In terms of stomach side effects, we often prescribe proton pump inhibitors or other drugs to inhibit gastric irritation. They won't experience that their kidneys are not liking these drugs, and they probably won't experience that their liver isn't liking these drugs either. So blood tests are important for monitoring the liver and the kidney. Blood pressure can go up, so that's something that needs to be tested objectively. So that's anti-inflammatory drugs. Paracetamol is another drug that we use a lot for pain relief, and it actually, even though it's available over the counter, it's a very useful drug. And just because it's freely available does not diminish its benefits.
It's a very important message, because I think a lot of people sort of, feel it won't be strong enough because it's an over-the-counter medication.
Yeah. But it is. The problem is you can only buy a small amount at a time over the counter. So when taken by prescription, you can get enough to take your 1 gram 3 times a day, or even 4 times a day. So it has to be used a little bit with caution in people who have liver disease and so on, but it really is a very good drug and quite safe. And then we get on to other drugs like methotrexate would be the most common drug used for rheumatoid arthritis, first line worldwide. It's a very good drug. It's taken once a week, and it's started at a low dose and usually increased to the dose that the person needs. Very important to monitor blood tests, so typically full blood count, liver function and renal function. And again, it's really important for the patient to work with their doctors to make sure they get their blood tests done. I know that patients might expect that their doctors will remember each individual that they need their blood tests done, but it's really, really important for patients to take responsibility as well. If everybody takes responsibility, they won't run into trouble. So yes, the doctors have responsibility, but so do the patients. We usually do a chest radiograph for patients starting methotrexate and pulmonary function because sometimes and very rarely they can run into difficulties with their lungs, and if we don't have those baseline tests, we won't know if the difficulty with the lungs is the drug or something else.
Yeah, sure.
And then we have drugs like hydroxychloroquine, lovely drug, very safe, but we need patients to have intermittent eye tests. It's very rare for them to run into difficulties, but they need to be tested. There's salazopyrene, again, very useful drug, but again, especially initially, they need their blood tests done and they need to be informed about side effects, which again can be feeling sick, feeling dizzy, but it's the important side effects come from the blood tests initially. And then we get on to our biologic drugs, which are typically given by injection. There are many types, and they are counteracting various what we call cytokines in the body that are driving the inflammation. And the biggest side effect with those drugs tends to be infection. And so our threshold for worrying about infection in patients receiving those biologic drugs is quite low. It may be that we'll be discussing those drugs in more detail later in our conversation.
Okay. And I guess another question that kind of follows from that is, how long will it take the medication to work? And how do you know if it's working?
So, depending on the drug, it'll take shorter or longer. So drugs like methotrexate can take up to 3 months for the full benefit to be felt. And how we know whether it's working or not is, well, first of all, symptom improvement. We use blood tests to know. So when we assess somebody first, we do what we call their inflammatory markers. And inflammatory markers will be the C-reactive protein, or CRP, the ESR, and another favourite of mine is the fibrinogen. Not everybody uses fibrinogen, but I find it a very useful concurrent inflammatory marker for our patients. But if I could only use one, it would be the CRP. So the CRP will typically be elevated in somebody initially, and we can watch it fall. There are a very small minority of patients who don't have elevated inflammatory markers, and in that case it's a little bit more difficult. So we have to use our physical exam, soft tissue swelling for example, and then a lot of rheumatologists now use ultrasound to assess these patients, so they can see fluid in the joints, or they can use what we call the Doppler signal to show inflammation in the joints, and that can be very useful.
Okay.
Yeah.
And I suppose once somebody starts on medication like this, for their whatever form of arthritis they have, are they generally on medication for life?
Not always. So depending on the condition, for example, rheumatoid arthritis can be described as either seropositive or seronegative. Seropositive rheumatoid arthritis is typically the one that has the positive rheumatoid factor and or a positive what we call anti-CCP antibody. So these are the two tests we do that can tell us whether or not the rheumatoid arthritis is seropositive or seronegative. And my rule of thumb is if somebody is seropositive, they will probably be on some form of medication for life. What we like to do is use enough medication initially to put the fire out, as I put it.
Yeah.
So you want to put the fire out, they feel really well, they've got energy, they can do their exercise, they're sleeping well, they don't have morning stiffness, and radiographically there's nothing showing up. Then we'll start pulling back on those medications. So if they're on methotrexate, we'll try and lower the dose gingerly. So we give them intervals at lower dose to make sure they're not having a flare. And the same goes for the biologic drugs. So if you're on an injection, say every 2 weeks, you might be able to go to every 3 weeks or then every month. And sometimes we'll find that they will experience a flare with time, in which case you just increase up the medication again. With the seronegative arthritidase that look just like rheumatoid arthritis, but they've a negative rheumatoid factor anti-CCP antibody, it's possible that they will in due course be able to discontinue the medication entirely. I've certainly seen that happen.
Okay. And in terms of, once a person, has their diagnosis and they're on treatment, how often might they see their healthcare team, their rheumatologist, their GP? How often would they be checking in?
So initially, depending on how severe the arthritis is, if they're really very, very inflamed initially, they may well be seen 6 weeks after their first assessment, because at that first assessment they will have been prescribed medication. It might be steroids, or they might start on methotrexate right away. So I would typically see them within 6 weeks. In really, really severe people, I might even see them 2 weeks later. So I think the more severe they are, the more frequently they'll be seen in the beginning. Then with the passage of time, as the disease comes under control, you might leave a 3-month gap and then a 6-month gap. Typically, they'll be seen every 6 months by the rheumatologist. With COVID and the advent of using virtual consultations or telephone consultations, it's now happened that patients that might live, say, in Donegal or the west of Ireland or far away, what we can now do is do a telephone consultation and get those blood tests sent to us. So if somebody is perfectly well and have no symptoms, once we can see the blood tests, then we mightn't see them for a year. So really it depends on how severe, if they're stable. Yeah. Exactly.
Yeah. Okay. So we've spoken a good bit about rheumatoid arthritis, when we're speaking about inflammatory arthritis, but are there other types of inflammatory arthritis that follow perhaps a different sort of treatment path to what we've already discussed in terms of rheumatoid?
Well, Gráinne, I am so glad you asked me that, because it is really important to talk about crystal-induced arthropathies. The most common one that people will be familiar with is gout. And gout is a condition that occurs in some people who have elevated uric acid in their blood. So it doesn't happen in everybody with elevated uric acid in the blood, but in those in whom it does happen, the uric acid causes precipitation in the joints of monosodium urate crystals, and that's why it's called a crystal-induced arthropathy. And it is becoming more and more common, and the treatment of it is worldwide very poor, and that's why I think it's really important to talk about it. It can mimic other forms of arthritis too, but it typically is excruciating when it happens. Yeah. And one of the big problems with it is that there's a bit of a stigma associated with it.
Yes, it does conjure up images.
Yes, which is most unfair. So it conjures up images of the boozer and the gourmand and the bad living person, when in fact it's something that does run in families, and what underlies it is that you'll have a genetic predisposition to not clear uric acid through the kidneys. And so you can have some people who are extremely healthy living, who don't drink any alcohol and who are as skinny as rakes, and they get gout. And people, I've been told by patients that they've been reluctant to come and seek advice because they felt it was a reflection on them. So if there's one message I want to get out there, and it's that gout is a serious condition. It can damage your joints, and if it's not treated, there's an elevated mortality associated with it because of cardiovascular disease. The mortality associated with rheumatoid arthritis has steadily diminished over time, but that has not happened with gout. The treatments for gout are very, very effective if they're taken properly, and the treatments are lowering uric acid to the level that you need by using drugs such as allopurinol or febuxostat. And we use a drug called colchicine in the beginning to stop people getting attacks while we lower the uric acid. So it is the one treatment that is so effective that you can get pretty much a cure of gout, except for you do need to keep taking treatment.
And that point you mentioned there, isn't that one of the difficulties as well, when people
adhering to the treatment?
Adhering, yes, in terms of when their flare subsides.
They say, oh, I'm cured, and then they stop taking their treatment, and the next thing you know, they're back having a flare again. And it tends to happen at the most inopportune times, like a CEO about to give the annual review will get an attack of gout. So it's really worth treating. And then the other one, which is very common, is that associated with CPPD. That is the term to describe calcium pyrophosphate dihydrate crystals. And these are calcium containing crystals that increase in prevalence in patients as they age, and it can cause an arthritis identical to septic arthritis. And we find that patients are often admitted to hospital with recurrent episodes of what's presumed to be septic arthritis, but it isn't. It's this calcium crystal arthritis. And the way to diagnose it is by taking a sample from the joint and putting it under polarized light microscopy, and you can see the crystals. And that's something that we have a particular interest in our hospital. And so we're really trying to broadcast the importance of making a diagnosis, because it can avoid patients who are often elderly being admitted to hospital and getting intravenous antibiotics. So I'm really glad that you brought that up, and you've got very good information in Arthritis Ireland about gout and how it's managed.
Okay, thank you very much. And I think moving on now, I mean, one of the areas that there's always keen interest in is the whole area of complementary therapies. You know, are there any complementary therapies that a person might consider that might help? Or even how would they go about assessing whether something might support them in their journey with their disease? Okay,
well, people find out a lot about complementary therapies from other people, there's no doubt about that. Complementary therapies don't tend to get as much clinical trials, if you like, because who's going to pay for them? But there are certainly anecdotally complementary therapies that people find helpful. There has been some research done into consuming fish, for example. It's not exactly a complementary therapy, but fish oils can be bought over the counter, so I think you could consider them. There seems to be some evidence for turmeric as being anti-inflammatory. There's an awful lot of interest in the microbiome now, so people tend to take medications to address the microbiome and improve things, and I think there's an evolving evidence for that. There was at the American College of Rheumatology conference a few years ago, there was a whole session on CBD oil, and we're often asked about CBD oil. If people ask me should they take it, I don't object to it. I say try it if it helps. There's a certain amount of, if it helps you, why not? Massages, reflexology, all of those things help some patients. If it helps, definitely, why not? So that would be my view. I tend to advise people to avoid buying the weird and wonderful over the internet, because you just don't know what's going to be in those products.
And it can cost you as well.
And it can cost you a fortune. There are definitely people that benefit from acupuncture. So I tend to have quite an open mind about these things, because I don't think we know everything. And the day you stop being curious is the day you stop being a good practitioner.
Of course, a diagnosis of arthritis has a huge, impact on a person's daily life. In terms of lifestyle modifications, that might accompany the actual medical treatment that a person's undertaking, what lifestyle modifications might a person make?
Lifestyle modifications are extremely important, and in the first instance, I think physiotherapists can be really helpful in this also. But let's take some of the classic lifestyle things that people say need moderation. Well, first of all, we know that smoking is associated with the generation of anti-CCP antibodies, which is something that underlies rheumatoid arthritis. So smoking is definitely something to be avoided. It can also exacerbate osteoarthritis because it causes damage to connective tissues. So people who smoke are more prone to get multi-level degenerative disc disease. So they might get prolapsed discs and need back surgery sooner. Patients who get worn rotator cuffs in their shoulders, some surgeons won't operate on them if they're smokers. So smoking is definitely something that needs to be discontinued, and I suppose it's nice to note that smoking is much less common now anyway. Excess alcohol, if you're in pain and you like a drink, you may be more prone to drinking more and thinking that it might improve your sleep and help your energy. Well, we know that even small amounts of alcohol can really disrupt your sleep. So minimizing alcohol is something that people can and should do. Also, when people are being treated with methotrexate, they're advised to reduce their alcohol consumption because of side effects. But one of the biggest problems I see now in terms of managing arthritis is the worldwide, at least in the third world or the first world, epidemic of obesity. That's something that really, really concerns me. Obesity is something that's associated with increased inflammation in the body. It's also associated with chronic widespread pain. So if you have joints that are painful associated with your arthritis, whether it's rheumatoid or psoriatic or ankylosing spondylitis, it's exacerbated by obesity. And there's something that really bothers me is the amount of fast food restaurants and businesses that sell foods that are really bad for you proliferating everywhere. They weren't there years ago. And I worry about marketing. So I think it's really important for people to become really mindful of what they're eating. If you have childhood obesity, that's really difficult. But if you were in your 20s and you weren't obese, then you have the opportunity to address it for sure. And I try to take a positive approach with my patients. We check their BMI and advise them that even a few kilograms might help. And I find in general people are really happy when it's brought up. And we direct them to organisations such as Slimming World. The main thing is to be mindful and look at what you're eating and try and make it healthy. We don't expect people to be hungry, but just be mindful. And
in terms of having any advice for somebody that, for example, may have a higher BMI than may be advised, just to get started, because I think that can sometimes be the difficult thing. It's really difficult.
Where I think devices such as a Fitbit, watching, it's not all about exercise, obviously, but the two are complementary. So watching how much you're doing every day in terms of steps. So if you can't do 1,000 steps at once, we'll do them in broken up fashion. If you're in the habit of having nighttime chocolate, for example, maybe eat grapes instead. Mindfulness is the thing. Do I really need to eat this? And it's I want to emphasize, I think it's really difficult and we're surrounded by it. But the thing is to start.
And there is support out there.
There is support out there. And people will be sympathetic.
Yeah.
And it's awfully difficult. It really is awfully difficult. But it's really worth it for the future because it will really help.
Yeah. In terms of arthritis symptoms, one of the areas that's often discussed is about foods that may exacerbate symptoms or impact arthritis, and of course there's been many books, articles published over many decades about this topic. Are there any foods that a person should avoid when they have arthritis?
I think if an individual finds themselves that something bothers them, then by all means avoid it. There are definitely people that find eating, I don't know, lemons or sorry, drinking lemon juice or eating red meat, whatever it is, if it upsets you, definitely avoid it. But what I hate is when people are told you're not supposed to eat tomatoes, you're not supposed to drink orange juice because it will affect your arthritis. I don't buy that at all. If it doesn't bother you, then by all means, like, orange juice is good for you, as in, I don't mean the sugar-filled orange juice now, but natural orange juice is good for you. And anything, tomatoes are the basis for lots of foods. So I think it's important that people don't avoid foods like that just because there's this narrative around them.
Yeah. And we talked about the role of physical activity, and we know that exercise absolutely helps a person living with arthritis. Are there activities that are, I think one of the things people struggle with is what activities are safe to do, and that whole idea that maybe exercise is going to cause more pain. What would you say to people around those topics?
I suppose my overall philosophy is that the only exercise that's bad for you is no exercise. Okay, so that's where I start. It depends really on what condition you have. There's some pain that's kind of to be expected in somebody who hasn't done exercise for a long time and starts. If you're in an arthritis flare, then you kind of have to minimize your exercise. So the best treatment for an inflamed joint is rest, for sure. So putting that aside though, if you have, say, really bad knees, well, then you might find that a rowing machine works best for you. You need to find what your body part will permit. And that's where a physiotherapist can be really helpful. And sometimes group classes can be very helpful. So there isn't one size fits all, but again, I would say the only exercise that is bad for you is no exercise.
I think that's a very important message.
Yeah.
And maybe one of my last questions I have for you really is around this whole area of surgery. Now, we obviously I think most people enter into the management of their disease hoping that they won't see the surgeon.
Yes.
But I think it is a question that's at the back of a lot of people's minds when they're newly diagnosed. Will I need surgery?
Okay, so when you're newly diagnosed, you can't answer that question because you can't actually predict unless you've been left without treatment for years. Then sometimes if somebody comes in and they've been neglected for years or have neglected themselves, then you'll know that hip is shot and that it will need surgery. But the majority of people won't, especially with the inflammatory arthritidase now, because our treatments are so good. With osteoarthritis, they may in due course need, for example, a hip replacement or knee replacement, but our treatments, the surgical procedures are really good now. I would say that it's very important that the decision is a combined decision between the surgeon and the patient. So I would never buy that somebody should be told that joint needs replacement if they don't feel like it needs replacement. So it's all, again, it's a conjoined approach with the patient and the surgeon.
Yeah. Okay. And I suppose my last question, any last advice for somebody that's newly diagnosed?
It's a little bit of a shock to be newly diagnosed. However, the chances are that you will have been experiencing symptoms for some time, and getting a diagnosis provides a degree of certainty. And I think in some ways it's nice to get your diagnosis, be it an expected one or an unexpected one. There's hope no matter what the diagnosis is. You haven't just developed the condition on the day of the diagnosis, you've been living with it for a while. So now the day of the diagnosis is the day you can move forward, actually. So I would take a very optimistic view of getting a diagnosis. Hopefully you're feeling able to talk to your doctor, if you're not able to talk to your doctor, or not all practitioners are the right fit for you. So you can always change your doctor if you're not happy, but most people are happy with their doctors. And then you've got the wonderful Arthritis Ireland to provide support for you, especially when you're newly diagnosed. And they've a special programme now to help you when you're newly diagnosed. So there's great support out there. I think the main advice I'd have for people is to try and be a partner in your treatment. You can be the person that provides the best outcome for you, and you're all a team. So that would be my final message to people. Okay.
And on that optimistic and positive note, I will finish things today. Thank you very much, Geraldine McCarthy, for being with us today.
Absolute pleasure.
Thank you very much for joining us today. For more information on being newly diagnosed with arthritis, please log on to our website, arthritisireland.ie. You can also get support via our online Facebook groups and by calling our helpline on 0818 252 846. Thank you for joining us, and see you again soon.